Sir, we are live now. With all your permissions, I'm starting this session for
Yeah.
today. Good evening, everyone present here. I am Faraz from IDCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Quresh B. Maskati, sir. And let me share some of the achievement of sir. Sir has done MBBS, MS, DOMS, FCPS, FICS, and consultant ophthalmologist at Maskati Eye Clinic, Mumbai. And today he is going to discuss on a very important topic, that is glaucoma, silent thief of sight. And this is we are going to discuss on the occasion of glaucoma awareness month. So to know more about this topic, I would like to invite sir and hand over this session to sir. Sir, stage is yours, you can proceed from.
Thank you, Faraz, and welcome all of you in Glaucoma Awareness Month. Why do we have Glaucoma Awareness Month? Why don't we don't have a Cataract Awareness Month or a Retina Awareness Month? Reason being that glaucoma is a silent thief of sight. So unless we make people aware of that there is a disease called glaucoma, many of them don't know it till it is too late. That is why world over we have a glaucoma month in January. When vision loss occurs due to cataract, patient feels that my vision is blurry and immediately rushes to the doctor. If the retina detaches, he feels his vision is suddenly lost and he runs to the doctor. So there is no need of an awareness month. But in glaucoma, his eye pressure rises. 80% of those with eye pressure rise don't get even headaches. And the field of vision gets cut from the periphery to the center. So he still sees everything in the middle. So he thinks all is well. So that is why we have an awareness month, and I'll give you certain salient features of glaucoma, which you can then spread to all your patients. Let us first revise a little bit of the anatomy of what is glaucoma. The eye produces a fluid called aqueous humor. It forms from a factory which is called the ciliary body. The ciliary body, where I've written fluid forms here, that's the ciliary body. Ciliary body has ciliary processes which through tiny ligaments called suspensory ligaments hold the lens of the eye. So the fluid which forms in the ciliary body then travels through the pupil. Pupil is the opening in the iris, the brown portion of the eye, and bathes the front portion called the anterior chamber. The cornea derives its entire nutrition from this fluid. So this fluid is necessary. This aqueous humor is necessary. It bathes the inner lining of the cornea. And then at the junction where the cornea meets the sclera, or the transparent portion meets the white portion of the eye, there is a meshwork where I've written fluid exits here. There is a meshwork called the trabecular meshwork. It's like a netting. And through that, the fluid flows out under the conjunctiva over the sclera. It's called a uveoscleral outflow. Uveo is the ciliary body. Iris, ciliary body, all that is called the uvea. So this is the normal pathway through which the fluid flows, and the eye is maintained at a certain pressure. Just like when you put water in a balloon, there is a certain pressure. That pressure varies, and up to 21 millimeters of mercury. That is how it is measured. The unit of measurement is millimeters of mercury. So up to about 21 millimeters of mercury is considered into inverted commas normal eye pressure. Just like you have a normal blood pressure of 120 by 80, you have a normal eye pressure of 21 or less. So what is the definition of primary open angle glaucoma? When I say open angle, obviously there is another one called closed angle glaucoma, but closed angle glaucoma is where the angle of the eye through which the fluid flows out is very narrow. It gets clogged or blocked, and the patient realizes it most of the times. He gets an acute attack and pain. We are talking about the silent thief of sight, which is open angle glaucoma. So open angle glaucoma by definition is a chronic, progressive, and most important, irreversible multifactorial optic neuropathy. That means the pressure in the eye rises and the nerve of the eye, the optic nerve, gets compressed. It's called an optic neuropathy. So it's characterized by an open angle of the anterior chamber through which the fluid flows out, changes in the optic nerve head, and a progressive loss of the peripheral vision. As I said, the central vision remains okay for a long time, but it's the periphery which gets constricted. The last visual vision to go is the central vision field when the patient becomes blind in that eye. So elevated intraocular pressure is an important risk factor for open angle glaucoma. Means that you can have open angle glaucoma with a normal intraocular pressure as well. But most of the times the intraocular pressure is raised, which gives you some indication that the nerve is also getting compressed. So you have in open angle glaucoma something called normal tension glaucoma as well. So how do we measure the angle of the eye? So we have to first, to find out whether it's an open angle or a closed angle, the angle of the eye is called the gonio or the angle. So gonioscopy is measurement of the angle of the eye. So in the old days and even now, we used various mirrors called gonioscopes, as you can see in the picture of someone holding a gonioscope to the eye. They were called 2-mirror, 3-mirror, or 4-mirror gonioscopes because we had to see the angle in 360 degrees. So if it is 2-mirror, you have to rotate the mirror all around. If it is 4-mirror, it became easy to see four degrees at the same time. So these were gonioscopes. Uh, Unfortunately, the art of gonioscopy is being lost, just as the art of clinical medicine is being lost. So you have easier methods now called UBM or ultrasound biomicroscopy. You can see that the whole angle is beautifully shown like a CT scan. It's using ultrasound, and the same machine even measures the angle. It tells you it is 40 degrees, 43 degrees, whatever. It uses a 50 megahertz probe. Not content with that, after that came something called anterior segment OCT. OCT is like a CT scan, ocular CT scan. You can see that a picture of the OCT where you can not only see the angle, but you can see the cornea, the iris, the pupil, the lens, everything almost as if you were walking inside the eye. So obviously it can also measure the angle, tell you whether it is narrow or close. So these are three methods by which we measure the angle of the eye. Most important, I'm going to repeat this off and on again and again in these 30 minutes, that open angle glaucoma most of the time does not have any symptoms. So how do we prevent the damage? Most important, if you're a smoker, you need to stop. Researchers also believe that good nutrition can help. Maintaining a healthy weight, the more the weight, the higher the chances of glaucoma. Control the blood pressure. The higher the blood pressure, the more the chances of glaucoma, though it's not always directly linked. Important thing to be physically active. Just as it is important for blood pressure, it's also important for the eye pressure. Yoga does tend to help to bring the pressure of the eye down. And go easy on the coffee. Too much of coffee, more than 6 cups of coffee a day, can increase the eye pressure. So these are just some tips that you can share with your patients on how to maintain a normal intraocular pressure. But most important, how do I protect my vision from glaucoma? So the important thing is regular eye examinations. As I told you, it's a silent thief of sight. There are no symptoms. It is only the eye surgeon, not the optometrist, not the chashma wala, not the person in the optical showroom, not the fellows who sell spectacles online. They are not going to do a regular eye examination. So comprehensive eye examination by eye doctors, not optometrists, can help detect glaucoma in its early stages. Why? Because we not only check the eye pressure, we do ophthalmoscopy by which we can look at the nerve of the eye. The second nerve, second cranial nerve is the optic nerve. It is the only nerve in the human body which can be seen by us. So we can look at it and see whether there is an optic neuropathy or a glaucomatous cupping or glaucomatous changes in the optic nerve happening. And if necessary, if we are suspicious, we can order more investigations. So it's important to know your family's eye health history because glaucoma tends to run in the families. And If you're a sports person, wear eye protection in sports or in industry if you are working in a factory or something, because trauma can cause glaucoma because it disturbs and destroys the angle of the eye. And if you have been diagnosed with glaucoma and you've been prescribed eye drops, please don't stop the drops because you don't find any difference. The problem is almost half of the patients to whom we prescribe eye drops, after 1 or 2 months, they find that they took it for 1 month or 2 months. They find there's no difference in their vision. They never had any pain. Then they wonder why exactly are we taking it? So they just stop on their own. And when they come to us afterwards, more damage has occurred because of glaucoma. So encourage your patients not to stop medicine until and unless the eye doctor has told them. So why are we discussing all this? Why am I talking so much about this silent thief of sight? Because it is the second most common cause of blindness in USA and European countries. And I'm talking about developed countries, advanced countries with a lot of preventive health care. In spite of that, 50% of patients in these countries still remain undiagnosed. That means for every 100 patients who are on treatment for glaucoma, there are 50 patients out there in the countryside who have got glaucoma, don't know it, have not seen a doctor, and are going to go blind in due course. Open angle glaucoma patients are asymptomatic until they have severe visual loss. If you see that picture of those two coconut trees on the beach, you can see the whole coconut trees, both the trees, the beach, the water. But a glaucoma patient, when the peripheral field loss, he can see only a little bit of the coconut tree, little bit of the water. The periphery is all black, as you can see. So the peripheral loss goes, but he's looking at the tree and he can see the coconut. So he says, I'm all right. I don't see anything wrong. So there are standard validated diagnostic parameters. Three things that we check for glaucoma. One is optic nerve, called ON or optic nerve. The head changes. That means I told you we can do a fundoscopy or an ophthalmoscopy and we can actually look at the optic nerve. You see that the picture on top, that is the optic nerve which is seen. The white portion is the optic cup, and the whole optic nerve is called the optic cup or the optic disc, and the whole thing is called the optic nerve. So you do what is a cup disc ratio. The cup, the white portion, should be not more than 0.4%, 0.4 of the optic disc, the whole optic nerve. If it is more than that, like you can see, it is occupying an area almost 70%, 80% of the optic nerve is occupied with the cup. So the cup is expanded. This is a sign that the optic nerve is under pressure and it is slowly dying. The nerve fibers are dying. 2 million fibers go through, connecting every retinal cell to the brain through this optic nerve. It's like a TV cable. How do we? So one way of looking at the optic nerve is by using the ophthalmoscope. The other way is we do visual fields. So we give the patient, we put the patient automated visual fields, also called VFA or visual field analyzer. And the dark portions that you can see are fields which is lost. So you can only see the little gray area in the center. The black is all lost. And of course, we check the pressure of the eye to see whether it is normal or raised. So let's go to each of these. So previously, because we had to rely on our memory, we, as resident doctors, we made drawings of the optic nerve and the optic cup. So you can see the picture there of the optic cup, which I've shown you. And on the right, the glaucomatous disc with increased cupping. The cup is enlarged. See, compare it to the other color picture on the left. And now we get good fundus cameras. Fundus is the retina, so good fundus cameras which can take serial excellent images of the optic disc. And if I take a picture today, take a picture every 3 months for 1 year, and the fundus camera I can connect to artificial intelligence, which tells me whether the optic cup is increasing or not, the cup disc ratio is worsening or not. So I don't have to rely on my drawings. I don't have to rely on just serial photographs. I can use artificial intelligence to tell me whether the nerve is getting compromised. So if the nerve is getting compromised, it is worsening. I know that I need to reduce the eye pressure even more than what it is. So this is CDR, is known as cup disc ratio. It's an important ratio that we measure. I won't go into details of this. Second, I told you, so one is the looking at the optic cup. optic disc. Second is visual field analysis or VFA. There is something that's called perimetry. In the old days, there was a manual perimetry where we moved a lighted object in different fields, but now it's all automated. The two commonest machines used are the Humphrey and the Octopus perimeters. And this, the standard automated perimetry or SAP, is the gold standard for detection of all visual field defects. So you get a printout, something like this, and you can see the black portion in the upper large picture. The black portion is the part where he is not seeing, and the light area is the area where he is seeing. So you know that there is an upper half field loss, which corresponds to nerve fibers entering the eye from below, because it is 180 degrees opposite. So these are some of the pictures. You see the left side showing severe field loss. This is using Humphrey visual fields. I don't want to teach you everything about fields, but just look at that. You can see severe field loss on the top, the large black portions, and in the other picture, mild field loss, where you can see some areas with little darker gray, but the rest of it is quite light. The light areas are normal. So mild field loss, severe field loss, we can make out by doing this visual field analysis using Humphrey or Octopus perimeters. And the third thing is the intraocular pressure. So normal pressure, I told you, is less than 21 millimeters, but about 50% of patients have intraocular pressure less than 21 millimeters of mercury at the time of diagnosis. So that's called normal tension glaucoma. Means the pressure is normal, but his field of vision is affected or his optic nerve is affected. I would still reduce the eye pressure to below 21. I'd bring it down to 10, because it has been proved that lowering of intraocular pressure reduces the risk of glaucoma progression. There are various ways of measuring the intraocular pressure. This is one of them, called a rebound tonometer. The standard is what is called Goldman applanation tonometry. This is what is being done in the picture. It's done on an instrument called a slit lamp. That's the gold standard. Goldman applanation tonometry, or GAT, is a true measurement of the intraocular pressure. We won't go into the details again. So to summarize those three, I told you, measurement of intraocular pressure, visual field analysis, and we measured the gonioscopy. Now, we have now in the last 10 years or so, we've gone further into even more advanced imaging techniques. One is, I told you about the OCT. OCT not only for the angle of the eye, that's called anterior segment OCT, but you can do a posterior segment OCT, optical coherence tomography. And then you have Heidelberg retinal tomography and scanning laser polarimetry. These are some additional investigating techniques, so that we find out the RNFL is the retina nerve fiber layer. Retina nerve fiber layer, retina has got 10 layers. The uppermost layer is the nerve fiber layer, from where every retinal cell is connected through the nerve fibers, which goes through the optic nerve to the brain. So if you see the picture, there is the little hills and dales, and you can see the black line is going through the green portion. If the black line is going through the green portion, that means the nerve fiber layer is normal. If it dips down into the yellow or the red portion, that means that the nerve fiber layer is affected. That means there is glaucoma. Again, so this is called the RNFL, which is done by an instrument called Heidelberg Retinal Nerve Fiber Layer Analyzer. Let's move on to how is glaucoma treated. So I told you that once we diagnose glaucoma, we need to treat them. So the most important is medical treatment. Various eye drops are given. They either decrease the production of aqueous humor, that means the factory, the ciliary body is told to produce less, or they increase the outflow of aqueous humor. They dilate the vessels, they dilate the passages through which the fluid can go out. If you imagine a wash basin, then you can the pressure in the basin can rise either if you open the tap too fast, more than what the basin can drain, or you clog the mori, you clog the outlet. So these are two ways in which the pressure in the eye increases. So either you can reduce the flow, that means reduce the tap in the basin, or you make the openings in the base wider so that the water can flow out. Exactly the Bayesian principle is what we do for treating glaucoma. The eye drops either decrease production of aqueous or increase the outflow. But patient compliance is crucial. That is where you come in. I want you to take this message to everybody you know who has glaucoma, or any patient who tells you they have glaucoma. Please don't stop medicine. I won't go into the details of the various medicines because it's outside the scope. Our idea is to make you aware of everything about glaucoma. Then some of the patients who are not compliant, or the pressure is raised in spite of the medicine. We give two medicines, three different medicines, and still the pressure is raised 28, 30, 40. Then we may have to do surgical procedures. The commonest anti-glaucoma operation is called trabeculectomy. In the big picture, you can see that we have made a new pathway. We opened the sclera and made a new pathway for the fluid to flow out. It's called trabeculectomy. And if this is not possible or trabeculectomy has failed, we can put in a valve to inside the anterior chamber. We put a valve which drains the fluid out, and the valve usually doesn't get blocked. So that's called glaucoma shunt surgery or valve surgery. The commonest valves are the Ahmed glaucoma valve or the Barvelt valve, which are used. Some newer shunts have also come. Just to complete the story, for mild to moderate glaucoma, they don't work in severe glaucoma, and they are extremely expensive. Trabeculectomy is much cheaper to do, but this at the time of cataract surgery, you can insert this like a little valve there through a very minor procedure. And this is now the fashion of the day for those who can afford it, but it doesn't lower the pressure too much, so it can be used for severe glaucoma. What is the post-op care after surgery? You can resume work almost immediately. Avoid water going into the eyes for a few days. There's no need of dark glasses or sitting in any dark room. No need of bed rest. They can cough, strain at stools, lift weights, etc. They can use cell phone, computers within a day. So surgery is quite safe and resumption of work is almost immediate. To summarize, therefore, glaucoma is a silent thief of sight. Most patients do not realize loss of peripheral fields until it is too late. All patients with family history of glaucoma and all above 40 years should have an annual eye examination by an eye doctor. Glaucoma occurs most in adults after 40. So please encourage every single person you meet, whether they come to you for blood pressure checking, diabetes, or they come for any other reason, even a hernia or hydrocele, the above 40, have you had an eye examination by an eye doctor? Please go. And then the eye doctor will call him annually. Because glaucoma can cause visual field damage even if the intraocular pressure is normal. So we don't depend on optometrists. And compliance with treatment is essential to prevent blindness. I thank you so much for your patient hearing, and I'll be very happy to answer any questions. Thank you for us.
Thank you so much, sir, for your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, I can see, sir, we have received some question. With all your permission, shall we take this question?
Please.
The first question is from Dr. Arpit Aparayit Singh, and he's asking, how do you differentiate between open angle and closed angle glaucoma in clinical practice?
So we use the gonioscope that I told you about in clinical. I am very fond of the gonioscope. I immediately, any patient of glaucoma, I put the gonioscope in on slit lamp. I can see the angle and measure it and see whether it is open or closed. But for those who don't use it, they can get an OCT done, or they can get a UBM done and get the angle actually measured. So it is not very difficult to tell. Thank you.
Thank you so much, sir, for answering. Another question is from Dr. Singhania, and he's asking, how are artificial intelligence and machine learning being integrated into glaucoma diagnosis and treatment, sir? What's your point of view on that?
It's a very good question. I answered it partially now. When we do visual field analysis, when we do fundus photography, retina optic disc photography, previously we used to rely on our own human intelligence. And I would say that, I think the cup has become a little deeper, little larger. And we would actually use a measure tape to measure the cup and the disc. but the photograph could have been taken at different magnification, so it was not always very clear. So now we don't have to rely on this. We simply put all the serial photographs are attached. The machine is attached to a computer using artificial intelligence. It tells me that the examination you did in June and the examination you did in December, 11% drop in the cup disc ratio. It has worsened by 11% or 15%. Similarly, for visual field analysis, I don't have to see how much is black and how much is gray. It tells the using artificial intelligence, it tells me that there is a 15% worsening of the field over the previous field. So, and not only that, is very good for patient compliance, because I tell them, look, computer ji ne bola hai, computer ji has told you that you're not putting your medicine, your field has gone down, your optic nerve is becoming worse. You better put the drops, otherwise you'll go blind. So previously they didn't believe me because they didn't see any difference. No, life was normal for them. Now computer ji tells them, so they follow. Thank you.
Thank you so much, sir, for answering this question, sir. Moving forward, I can see one last question from Dr. Snehali. She's asking, what are the potential side effects of long-term use of intraocular pressure lowering medication and how long they are managed?
So there are two main things. One is what is called tachyphylaxis. That means that after some time the efficacy of the drug goes down. Suppose I put for example, there's a drop called timolol maleate, which is an anti-glaucoma drug. You put it for 5 years, 10 years, the pressure came down from 31 to 21. Now suddenly the pressure is rising up again after 10 years, because now the eye has got used to it. It is not effective. So you have to change. Luckily, now we have several other classifications, classes of anti-glaucoma. If one doesn't work or there is a tachyphylaxis, then we can go for another one. And the other thing is dryness of the eye. The ocular surface gets damaged with the drops. So the pharma companies are realizing it, and they're adding artificial tears in the glaucoma drops, and they're reducing the amount of preservative in the drop or making it preservative free so that the ocular surface is not damaged. Thank you.
Thank you so much, sir, for answering all the questions, sir. I hope, sir, you have done justice to this topic, sir. So I can't see any more questions, sir. Sir, as there is no more question, with all your permission, shall we conclude this session for
Sure.
today?
Thank you.
Welcome, sir, and we would like to see you in future also with different topics, sir. Till then, take care of yourself, sir. It was really nice to have you, sir. Thank you
Thank
so
you.
much, sir.
Okay. Bye bye.
Take care, sir.
Thank you.